Hi there, my name is Dr. Damien Rowland. I'm a paediatric emergency medicine consultant who works at the Leicester Royal Infirmary. And I'm just going to be talking about a few things that I do in my job. Sorry to start with a stark slide, but the essence of paediatric emergency care is sifting out the vast majority of children who are relatively well or have a mild injury from those who are seriously unwell and require an urgent intervention. And this is very challenging and often results in harm and mistakes. And this talk is going to be about some of the methodologies that I use to try and avoid making mistakes in my practice. I'm not going to say that pediatric emergency medicine is an easy job, but it's certainly an extremely exciting one. And I think it's one in which you get a great deal of reward. So here's a little game for you. There's a load of snowmen in this field. What I want you to do is spot the panda. I'm going to give you 10 seconds to spot the panda. And there will be some of you who have spotted it immediately and some of you who will take a bit longer. It's okay if you take a bit longer because this is quite a difficult challenge. Okay, so time is up and there is the panda. The interesting thing is once you have seen the panda, it's virtually impossible now to unsee it. So if I show this picture again, your eyes will be drawn straight to the panda. But there was a period of time when in fact you couldn't see it at all. So here's another example. This picture hopefully is flashing in front of you, and actually every time it flashes it changes. Now there is something definitely different about this picture as it flashes between the two, and no, it's not the number of soldiers in the picture. It's not got anything to do with if they're wearing a hat or not. It's got nothing to do with a color change. It's actually the plane. It's a fundamentally important part of the plane, and I hope you notice now actually it's the engines going in and out of the shot. So again, there are periods when you're looking at something and you're looking at them very intently and they're your sole focus, that you can miss things that only retrospectively become obvious. Now, this is from a more medical example. This is actually published in a journal. It was a CT scan, and it was a group of 20 CT scans that were shown to expert radiologists. Now, some of you will have spotted the abnormality in the CT scan almost immediately, and some will take a bit longer. And in fact, in the study that was done, about 20 to 25% of radiologists didn't spot the gorilla in the CT scan. And that's not because they're bad radiologists, it's because they're not looking for that type of signal in what is, to them, normal noise. They're looking for a normal CT scan, and they're looking for abnormalities that fit within the normal construct of abnormality. But things that are completely outside your expectations, you sometimes don't see at all. And this is called inattentional blindness. Now, there's also other errors that we can make in pediatric emergency medicine, and it's worth you thinking about what color is this. The reason this is important is because bile is a significant finding if a child starts vomiting it. But loads of children vomit, and loads of children do vomit a yellowy fluorescent green color, and that's completely normal. But lots of parents think that lighty green color is bile, but it's not. It's a darker avocado green. And if we as clinicians can't agree on some of these colors, you can understand why mistakes happen. So my job in a large pool of relatively well people is to spot the children who are unwell, and as I say, require that more urgent intervention. And this is difficult because if you look at the probability of illness, inconsequential illness is extremely common, whereas life-changing illness is relatively rare. But if you miss it, clearly having meningococcal disease and delaying antibiotics has a significant impact on that child. They may even die. And that clearly is something that we want to avoid at all costs. Because of the impact it clearly has on the family, but also the impact it has on staff involved. Now, this is a kind of a spectrum of elucidating even more why this is a difficult problem, is that if we don't treat, but you're very well, that's not a problem. And clearly, if you look really unwell when you arrive and you can treat that quickly, then again, it's not a problem. The problem is in this middle section, whereby if you overtreat, you unnecessarily admit people and expose them to antibiotics they didn't need. But if you don't treat them, there is this risk of potential morbidity and mortality. And this is our daily dilemma. So what I want to talk is a bit about is decision making and how we do this in busy environments. One of the things I've worked on with colleagues is there are 4 factors that come into play when we're thinking about how to avoid missing the unwell child. And the first of those, physiology. What is a normal heart rate? This is a really good question when you do your pediatric attachments or you go into practice. Ask people what a normal heart rate is, because we don't really know. And there's loads of textbooks on pediatrics, but they actually all quote slightly different heart and respiratory rates. That does make it quite difficult, because if you're trying to come up with national standards and we can't even agree on what normal is, it's very easy then to miss abnormal. And then there's what I call kind of too much kind of sensitivity. So if a little baby who's less than 3 months or especially 6 weeks old presents and they have a temperature of 38.1 degrees, that puts them in a very high risk sepsis or illness category. And we know that there are lots of different signs that have risk factors for being seriously unwell. Kind of temperature is one of them. So having some signs of really being unwell, and there are others which have kind of very low impact. But temperature is one of those things which is a pretty hard factor. A febrile infant has a 10% chance of serious bacterial illness. Let me just go back to this slide. But if in this particular child, the temperature was 37.9 degrees, they wouldn't reach that threshold. But it's only a difference of 0.2 degrees C, which is within the limits of performance of tympanic membranes or digital thermometers. So you can see now that if you just go on the temperature and a clinical sign, that variation may lead you to undertreat or overtreat. And we get a bit obsessed with scoring systems and doing something on the basis of a number alone. But I don't think that actually is a great practice. And what we need is more kind of holistic global ways of identifying these unwell children. And I think one of the things I'm making with this particular child is you have the child described in the observations charts, so their temperature, whether they're tachycardic, but also the child you see in front of you. What do they look like? Do they look unwell? What is your gut feeling telling you? And you have to bring both of those things together. And the underlying reason for this, and I really like this slide from Professor Rick Body, is there comes a point where something goes from negative to positive. So as I explained previously, that 37.9, if you go up 0.2 of a degree, you become 38.1, and that completely changes what the guidelines tell you to do about the child. But it's just an arbitrary line, and I think we need to remember that in all our clinical practice. Heuristics, these are shortcuts we use to come to a quick decision. I was trying to teach my daughter how to play Guess Who. She's 6 years old. We spent 20 minutes going over how the game works, asking about different colored hairs, whether you've got glasses, whether you're wearing a hat. And so I go, okay, I'll explain the rules to you. What's your first question? And she just goes, is it Anne? Wasn't quite expecting that. I looked at my card. Yes, it was Anne. And Anna goes, yes, brilliant. And we've never played Guess Who again, because she believes that she's an expert at it, having only had one question and made a lucky guess. And this is sadly a common feature of medical practice. When you start, you acknowledge you know nothing, but your confidence actually grows quite quickly in medical practice and in pediatric practice. And you actually have confidence above the experience that you actually have. And after a couple of years, you actually probably think you know more than you actually do. And then you'll make a mistake or something will happen and your confidence will kind of plateau again. And then eventually, over a number of years, your experience will build and your confidence will grow again. Nassim Taleb calls this arrogance in the face of competence. And this is a really difficult concept, but it is an important one to recognize. And then there are the biases. So the person who was announcing the winner of Miss Universe 2015, instead of reading out Miss Philippines, read out Miss Colombia, because they read from left to right and they saw first. They didn't really see the runner-up and they missed Philippines in the bottom corner. And you can think retrospectively, well, how did they do that? But you can see in the heat of the moment, when you're a bit under pressure, these mistakes can happen. And there are a number of biases, anchoring biases, kind of blind spot biases. And I really encourage you to Google kind of cognitive biases that screw up your decisions, because it's a really interesting read about all the biases that are out there. But as an example, a child presents to the emergency department, the assessment nurse categorizes that child with bronchiolitis as urgent. The child appears snotty, respiratory distress, unwell for a couple of days. They appear to improve with oxygen. And so when the junior doctor gets to see them, doctor phones colleagues on the ward, you don't need to review this one until the morning, that they're bronchiolitis, only need a bit of oxygen and nasogastric feeds. And in the early hours of the morning, the child collapses and they actually had a cardiac problem. No one had listened to the heart because they presumed it was bronchiolitis. And these are all the issues that occur in emergency departments over winter. Some external factors, I've mentioned winter, it's going to be busy, high patient loads, time pressures, multiple handovers. Inexperienced staff, I'm not saying bad staff, it's just if you're junior, you simply don't know as much. And there's a lot of diagnostic uncertainty. And you can see in the melee of an emergency department or busy ward, these are all contributing factors to the inattentional blindness and the cognitive biases that I've just described. And on top of that, agendas for both clinicians, which are about identifying immediate danger, but living with uncertainty. You don't need to know what it is, but you need to know what it isn't. Whereas the parents' agenda is that they want their child to be pain-free and they want certainty that the illness will go away. And we can't always offer them that certainty. And that produces a communication problem. And communication is absolutely critical. And I do a lot of research on safety netting. And that there's this difficult balance between those parents who aren't too concerned and you're not too concerned, that's easy. Or the parents who's very concerned and you're really concerned, that's easy as well. But what do you do when there's a kind of, you think there's no illness, but the child is, the parent is absolutely beside themselves with anxiety, and then the converse, you're really worried about the child, but the parent isn't, and there are sometimes safeguarding issues. This is a very difficult balance to come to. And the key thing is really listening to parents and hearing what they're saying. Because you need to address the concern about what they're worried about, not necessarily the child. And it takes sometimes a lot of deep diving into prior beliefs, some of the child's past medical history, some of the parents' past medical history, to be able to understand what really is driving their anxiety. And finally, one of the things about the environments in which kind of I work is not only do we need to recognize deterioration, but we need to have the right staff at the right time with the right skill set to be able to do something about it. So it's not just about recognizing the ill child, it's about having staff with the right skill sets to do the things that you need to do in a timely fashion. And so a lot of my time is spent in education and training or training others how to train others. And I think one of the things I really enjoy in pediatric emergency medicine is that the evidence changes in what we need to be doing. So we need to be constantly updating our staff. And it's a very exciting field of practice because of the way that we're dealing with variable demand, and we're dealing with a really uncertainty all the time. So it makes every day extremely different. For me, one of the critical things I do is observe, and that's short-term observation, just looking at the child, or sometimes just over a couple of hours to see what their trajectory of illness is. And I enjoy my job because I don't need to know lots of things, and I don't need to learn lots of drugs, and I don't need to know lots of causes of disease. I just need to be confident in my ability to spot the sick child, and that makes it an extremely rewarding job. And something that makes it a pleasure to work with children and young people on a daily basis. Thank you very much for your time. And I'm very happy to take questions via email. Just Google my name. Apologies, I can't be with you live today. Thank you very much.